Hello, everyone, and thanks for joining our webinar. This is Matthew Hegewald, and I'm joined by Navitha. We'll both introduce Navitha will introduce both of us, and this webinar is on matching the patient with the delivery device. When is nebulizer therapy the best choice? And this is a non-promotional, non-CME disease state program brought to you by CHEST and sponsored by Theravance, Biopharma, and Viatris.
Hello, everyone. My name is Navitha Ramesh. I am a pulmonary critical care physician in Harrisburg, Pennsylvania. I'm the assistant professor at Drexel University College of Medicine and the program director for the Critical Care Medicine Fellowship at UPMC in Harrisburg. I would also like to introduce Dr. Matthew Hegewald. He's a professor of medicine and the director of the Pulmonary Diagnostic Services at Intermountain Medical Center, University of Utah in Utah. Welcome, Matt, and welcome, everyone. So we have divided our session into two blocks. We'll talk about the pharmacological therapy in the first half of our session, and then we will talk about the aerosol delivery devices for COPD in the second half. So if any of our participants have any questions, I request you to type the questions in the chat, and all the questions will be answered to the best of our ability at the end of the session. So GOLD guidelines for 2023 were recently released, and there have been several changes in the GOLD COPD management guidelines, and we will go over some of them. So the pharmacological therapy for treatment of stable COPD focuses on reducing the symptoms for our patients, reducing the risk and the severity of exacerbations, improving the health status, improving exercise tolerance, and also in some population of patients with COPD, it could also improve survival. As we have heard before, bronchodilators are the highlights in management of stable COPD. And there are two types of bronchodilators: long-acting beta agonists or long-acting muscarinic antagonists. So the LABAs and LAMAs are preferred over short-acting agents. That's level 1 evidence, except in patients who have only occasional dyspnea. So if they're only very occasionally symptomatic, they can use SABAs. If not, LABAs and LAMAs are preferred. So this point is very important. When initiating treatment with a long-acting bronchodilator, the current preferred choice is a combination therapy of both a LAMA and LABA. That's again level evidence A. Inhaled bronchodilators are recommended over oral bronchodilators, and theophylline is not recommended unless other treatment options are unavailable or unaffordable for our patients. For COPD, long-term monotherapy with inhaled corticosteroids alone is not recommended. If inhaled corticosteroids need to be added, the recommendation is to add ICS to a combination of LAMA and LABA. And we will be talking about when inhaled corticosteroids are optimal in COPD patients. So the guidelines also take COPD and asthma as two separate diseases. So a patient can have both COPD and asthma. And if they show features of asthma, the treatment should always contain inhaled corticosteroids. In patients with severe or very severe airflow limitation, and they have recurrent exacerbation and have chronic bronchitis, phosphodiesterase inhibitors can be added to their regimen. In former smokers with recurrent exacerbations, macrolides like azithromycin can be considered. And statin therapy and beta blockers are not recommended to prevent exacerbations. So one other important feature of this new updated GOLD recommendations is the initial pharmacological therapy should be based on individualized assessment of symptoms and exacerbation. So now we are talking about tailored therapy for our patients with COPD. As you may recall, in the past, we used to call it Group A, Group B, Group C, Group D in the management of COPD. Now the updated recommendations combine Group C and Group D, and they are called Group E, as in exacerbations. So a patient who is in Group A, who has 0 to 1 moderate exacerbation, but that does not lead to hospitalization, and the MMRC score is 0 to 1 and CAT score is less than 10, the recommendation is you use a single bronchodilator. This could be a short-acting beta agonist, long-acting beta agonist, or a LAMA. Preferably, long-acting agents can be used. In the similar category, if the patient has less moderate, 0 to 1 moderate exacerbations, however, they are symptomatic with MMRC being greater than or equal to 2 and CAT score being greater than or equal to 10, the recommendation for initial therapy is to start a combination of LAMA plus LABA. Now we move on to the third group, which is group E, where the patients have greater than 2 moderate exacerbations or 1 or more hospitalizations related to COPD exacerbation. The group recommends starting LAMA and LABA combination in these patients. And if these patients have a blood eosinophil count over 300, then the recommendation is to add an ICS along with LAMA and LABA. So this is a big change from the prior grouping based on the GOLD recommendations. Group A, the slide is to reiterate that Group A can have either a short or long-acting bronchodilator, but long-acting is preferred. Group B is a combination of LAMA and LABA. And Group E, LAMA and LABA is preferred. However, if the patients have increased blood eosinophil levels, an ICS can be added to this group. So once we start a patient on initial regimen based on whether they're Group A, B, or E, it's always important to review the patient's symptoms and exacerbations over a period of time. We always have to assess the inhaler techniques and inhaler adherence and see which patients would qualify for non-pharmacological therapies such as pulmonary rehab. And every patient needs to be taught self-management techniques to manage their COPD. Once the symptoms are assessed and the inhaler technique and adherence are assessed, based on each patient, we would need to adjust therapy by either escalating the therapy, de-escalating, or switching the inhaler devices. And the various inhaler devices will be described later in this session. So that was for the initial management of stable COPD. Now we will move on to follow-up treatment. If the patient responds to the initial treatment, whether Group A, B, or E, if they're responding well, their quality of life is good, then we will maintain that therapy. If not, the follow-up treatment is based on 2 key treatable traits. They are 1, which is persistence of dyspnea, and number 2 is occurrence of exacerbations. Let's say your patient is on a short-acting beta agonist, and the patient continues to have dyspnea. So in those patients, we can add a long-acting beta agonist, a LAMA or a LABA. If they continue to be dyspneic, even after starting a long-acting bronchodilator, the next step would be to either switch around the molecules or change the inhaler device, but continue with the LAMA and LABA. However, if these patients continue to have exacerbations or have recurrent exacerbations, they fall in Group E. Again, if they are on a LAMA or LABA and their blood eosinophil count is more than 300, the recommendation is to add an inhaled corticosteroid along with the LAMA and LABA. If this patient's blood eosinophil level is less than 300, you would use a combination of LAMA-LABA. Again, look at the inhaler technique, the adherence, address the comorbidities. If they continue to remain symptomatic, however, their blood eosinophil level is increased, you can consider inhaled corticosteroids in them in addition to LAMA and LABA. Despite this triple therapy combination, LAMA-LABA ICS, if patients remain symptomatic and they are of the chronic bronchitic type, roflumilast can be considered. And if the patients are recurrent exacerbators and former smokers, azithromycin can be considered in them as well. This is just to reiterate the point about when to add inhaled corticosteroids in stable COPD. In Group E, that's important, not in Group A patients, not in Group B patients, it's in Group E or exacerbation group. If their sputum eosinophil level is more than 300 cells per microliter, or they have recurrent exacerbations, or if the patient has COPD and concomitant asthma, then inhaled corticosteroids should be a part of their regimen. So this was a study published in 2017 in European Respiratory Journal, where I have put some arrows where some changes have occurred. The initial treatment here in these patients, if they have daily symptoms, MMRC greater than 1, and they have exacerbation, the initial recommendation was to start one long-acting bronchodilator. So GOLD recommends a bronchodilator. It could be short or long, but a long-acting is preferred. And then if you go down, if they don't have enough control with the single agent and they have more dyspnea, dual bronchodilation, which is LAMA, LABA. If they continue to have exacerbations, this paper had suggested inhaled corticosteroid LABA fixed dose combination, but GOLD guidelines say if they have increased exacerbations and they have increased sputum eosinophil levels over 300, LAMA, LABA, ICS combination is preferred. So now we'll move on to some questions. So let's say we have a patient who has exacerbations despite a LAMA-LABA combination, or they had already been on a LABA-ICS combination. Which one of the following medications should be considered? Give it about 30 seconds here. Are we going to give them a LAMA-LABA-ICS triple therapy or LAMA-ICS combination? Or can they get theophylline, or would we be starting them on azithromycin? That's great. I think 93% have LAMA, LABA, ICS. Very good. Okay. So now we will move on to our triple therapy evidence. So very recently, 2 large studies have come out, randomized controlled studies called the IMPACT trial, which had about 10,000 patients, and the ETHOS trial, which had 8,500 patients. They had a similar population of COPD patients who were at a high risk of exacerbations. Both studies compared triple therapy, which is LAMA, LABA, ICS versus LAMA, LABA combination or LABA, ICS combination. In both the studies, the triple therapy, patients on triple therapy had lower all-cause mortality rates compared to LAMA, LABA and compared to ICS, LABA. And triple therapy patients also had reduction in moderate and severe exacerbation. So if you recall, most of the COPD studies focus on patient reported outcomes or patient quality of life outcomes, and exacerbations. So these big studies actually reported on mortality with COPD, and they did find out that triple therapy lowered the all-cause mortality rates. Now, moving on to our next question. At what serum eosinophil level would you consider adding ICS to an existing LAMA plus LABA regimen in COPD patients with frequent exacerbations? That's great. So over 300 cells per microliter. Okay, so we will move on to our, next one. So this is just to reiterate the point. Again, every patient is different, so not every patient can get the same treatment regimen. So now considering the evidence for inhaled corticosteroid addition in patients with COPD, there is the literature strongly supports the addition in patients with history of hospitalization for exacerbations with greater than or equal to 2 moderate exacerbations per year, blood eosinophil levels over 300, and history of concomitant asthma. We can consider using inhaled corticosteroids in addition to LAMA-LABA combination if they've had 1 moderate exacerbation, but their blood eosinophil levels are between 100 to 300. It is recommended to avoid the use of inhaled corticosteroids in patients who have repeated pneumonia events and their blood eosinophil levels is less than 100, or they've had mycobacterial infection. So this latest GOLD guidelines gives us very specific recommendations of when to add inhaled corticosteroids in stable COPD patients. So the next question, which of these medication components can be withdrawn if your COPD patient on ICS LAMA LABA has not had any exacerbation in the past year? Good. So inhaled corticosteroids is the answer for this question. So according to the American Thoracic Society guidelines, there was a conditional recommendation that inhaled corticosteroids can be withdrawn from triple therapy if the patient has not had any exacerbations in the past year. Once again, once you withdraw an inhaled corticosteroid in patients who appropriately had qualified for ICS in the past, it's very important to continue to follow the patients because withdrawal of inhaled corticosteroids may put them into recurrent exacerbations going forward. So it's very important to appropriately de-escalate, but also keep a close eye on those patients. So following this, we'll move on to the second section of our presentation.
Thank you, Dr. Ramesh. Okay, well, now we're going to talk about aerosol delivery devices. And some of the key points in GOLD 2023 regarding delivery devices and inhaled drugs in general, and that inhaled bronchodilators are really central to symptom management. And the choice of the inhaler has to be individually tailored and will depend on access, cost, prescriber, and most importantly, the patient's ability and preference. And it is essential to provide instructions and to demonstrate the proper inhalation technique when prescribing a device to ensure that inhaler technique is adequate and to recheck at each visit. And inhaler technique and adherence to therapy should be assessed before concluding that the current therapy requires modification. So now we'll talk a little about the different aerosol delivery devices for COPD medications. So an aerosol is defined as a suspension of liquid and solid particles produced by an aerosol generator. And the aerosol generators all have distinct advantages and disadvantages, including the pressurized meter dose inhalers, dry powder inhalers. And dry powder inhalers really have most of the market share now for COPD maintenance medications, soft mist inhalers, and small volume nebulizers. Once again, all these have different characteristics, but the optimal aerosol particle size for distal lung delivery is 1 to 5 microns. Remember, sizes larger than 5 microns deposit mostly in the upper airway. So the advantages, as we most know, of the meter dose inhaler is we have multiple medication classes. They're convenient, they're compact and portable, very short treatment times, and they accommodate low inhalation flow rates. And they have generally consistent drug output with both dose and particle size. The disadvantages are the multiple steps required, specifically the coordination of the actuation and the slow, deep inhalation, and then a breath hold. And there's variable oral pharyngeal and distal lung drug deposition, anywhere between about 8 to 53%, depending on technique and whether or not a spacer is used. Sometimes it's difficult to determine the number of doses remaining if you don't have a dose counter, although most do now. And many patients require a spacer for optimal drug delivery, and many patients don't use those spacers when they're prescribed. And then priming is required for most of the devices. The dry powder inhaler, once again, they have most of the market share for COPD maintenance medications. There's multiple medication classes. They're convenient, they're compact and portable, short treatment time. They're breath actuated, so you don't need to coordinate the actuation and the inhalation. And both multiple dose devices with the dose counter and single dose devices are available, and they don't require priming. But the disadvantage is multiple steps are required. It requires moderate to high inhalation flow rates, and that depends on the device intrinsic resistance. We'll talk a little bit about that. There's high oral pharyngeal and low lung drug deposition, right? Generally around 20%, but that's dependent on the ability to generate adequate inhalation flow rates. Single dose devices require more preparation, and they are affected by humidity. The soft mist inhaler are convenient. They're compact and portable, short treatment time. They accommodate low inhalation flow rates, and the aerosol duration of about 1.5 seconds allows easier coordination of actuation and inhalation. They have consistent drug output, both the dose and the particle size, and there's increased lung deposition between about 40 and 67%. There's fewer medication classes, and no ICS option is available currently. There's multiple steps required, both preparing the device, and you have to have some coordination, although it's less so than a meter dose inhaler of the actuation, inhalation, and breath hold. It's not breath actuated, and you do have to prime. Now, for small volume nebulizers, just as a sidelight, there's multiple different, there's 3 different general types of nebulizers, and we don't have really time to go into those in detail, but those included a jet nebulizer, which is what we're used to using, a ultrasonic nebulizer, and a mesh nebulizer. Now, there is a mesh nebulizer on the market that produces for maintenance therapy of COPD, and that's the LAMA glycopyrrolate, and it's the Lonhala Magnair using the Peri-E-Flow device. So that is available as a vibrating mesh nebulizer, although most nebulizers now are the jet nebulizers, are the medications delivered that use a jet nebulizer. And the other, there's multiple medication classes are available. The patient coordination is not required, it just requires tidal breathing. It accommodates low inhalation flow rates. Once again, tidal breathing, and you don't need to do a breath hold. It allows for dose modification. There's possible cost savings. We'll talk a little bit about that, in that in general, the nebulizer, the accessories, compressor, and some nebulizer medications are provided under Medicare Part B DME benefits. The disadvantage is less portable. There is the device preparation, assembly, and cleaning required. There's longer treatment times. You need a power source. And contamination is possible. There's some infection risk. This is just to go back to dry powder inhalers and the inspiratory flow rates required is higher flow rates generate greater drug deaggregation, which is needed for the small particle size and distal lung delivery. And device-specific recommended peak inspiratory flow rates have been published, and the clinical implications of suboptimal peak inspiratory flow rates and during and following acute exacerbations are unclear, with some studies showing that the inability to obtain the optimal peak inspiratory flow rate for a given device worsens outcomes, and other studies saying maybe it doesn't matter. This to the right is just to list some of the different devices, dry powder inhaler devices, the minimal and the optimal peak inspiratory flow rate. And once again, why this is important is the dry powder inhalers come attached to a carrier molecule, the active drug, and each device has an internal resistance, and then the airflow is generated by the patient's effort, and with that, you develop this turbulent energy, and it deaggregates the particles, and these are the small particles that are delivered to the distal airway. So just some basic principles for appropriate inhalation device choice according to the GOLD recommendations, and those are the availability of the drug and the device. So not all the drugs are available in all devices. For example, there's no ICS option in an SMI. The cost of the medication, that shared decision making is the most appropriate strategy for device choice, and the patient's cognition, their dexterity, their strength must be taken into account. And once again, the importance of reviewing technique and adherence before changing or adding medications. And providers should prescribe only devices they know how to use. And that's oftentimes difficult, as there's more than 10 different dry powder inhaler markets on dry powder inhaler devices on the market. So it's hard for providers to know how to use each one of those devices. So which of the following aerosol delivery devices does not include a triple therapy, the LAMA plus LABA plus ICS? Okay. Talk about seeing results, but the soft mist inhaler doesn't include a triple device. Now you could say, well, wait a minute, nebulizer, there's no triple combination it comes in one solution, but all the LAMA, LABA, and ICS all come in nebulized form. So a bit of a trick question, maybe. So these are the COPD medications that are available in the different aerosol delivery devices from the GOLD report. And you can see, once again, that nebulizers have, essentially all the components and the specific combination, and these are the specific combinations of LABA ICS, and these are the two currently available in the United States, the two triple therapy options. So which of the following aerosol delivery devices is generally covered under Medicare Part B, which is very important for our patients that have to pay for these medications? Okay. Yeah, so remember Medicare Part B, we'll talk a little more about that. That covers durable medical equipment, and so that includes nebulizers and their components and some of the medications. So Medicare Part B generally covers 80% of the cost for nebulizers, accessories, compressors, and some nebulizer medications. And you must meet the, quote, reasonable and necessary criteria. And this is determined by local, what we call LCD, or local coverage determination. That decides what is a reasonable and necessary. And LCD identifies the maximum number of daily doses and combinations of nebulized medications that can be used. And a provider must document the diagnosis and the clinical need for the therapies ordered. And this is just from cms.gov, and it just shows you the nebulizer drug coverage by Medicare Part B and the number of doses per month. So important for us, the inhaled steroid, or the nebulized steroid. These are the two nebulized long-acting beta agonists, and this is the nebulized long-acting nebulized LAMA. So some basic principles for appropriate inhalation device choice: the patient's ability to perform the correct specific inhalation maneuver for the device must be assessed, and DPIs are appropriate only if the patient can make a forceful and deep inhalation. If there's doubt, assess objectively, and that can be used with a device that measures peak inspiratory flow rate, specifically the in-check device. Or you need to choose an alternative device. Metered dose inhalers and soft mist inhalers, and once again, soft mist inhalers to a lesser extent because the drug is emitted over about 1.5 seconds. Those require some coordination between device trigger and inhalation, and the patient needs to be able to perform a slow and deep inhalation. If there's a doubt, consider a spacer or choose an alternative device. And nebulizers, so small volume nebulizers, should be considered if patients can't use a DPI, an MDI, or an SMI. So just a little bit about some of our problems with inhalers. This was a nice review in Chest a few years ago that looked at inhaler use and patient, as patient technique improved over time. And the bottom line is that these are the essential steps for these are just MDIs and DPIs, SMIs weren't included. And these are just the errors. And the key thing is that really only about 30 to 40% of patients were really able to use devices optimally, a MDI or a DPI optimally. And then, and the other key point about that study is they looked at did the ability to use these devices change over time? And the answer to that was no. There really wasn't significant improvement in the percentage of patients that were able to use devices optimally over time. And this study looked at is poor inhaler technique associated with worse outcomes, and specifically exacerbations in about 3,000 patients. And they looked at basically multiple different inhaler types and then whether or not they had at least one critical error. And a critical error was generally one in which you could reasonably expect that the drug wasn't going to have clinical benefit. And these are at least one critical error, how common they were, about 44% in PMDIs, 47% in the Respimat devices. So very common to have at least one critical error. And then kind of the important point about this slide is that if the patients that had a critical error, how often were they to have an exacerbation in the next 3 months and or the past 3 months? And basically, if you had at least one critical error, you were about twice as likely to have a severe exacerbation. So patients frequently don't use the devices appropriately, and there are some clinical implications to not being able to use an inhaler appropriately. And then, the Gold Report rightfully really encourages technique teaching. So we need inhaler technique teaching. It needs to be done essentially whenever there's a new therapy initiated, a new device initiated, and really at each follow-up visit, which is oftentimes difficult to do in our busy practices. And this study looked at the effectiveness of interventions to teach a metered dose and discus inhaler techniques. And it was a randomized trial. And so what they did is they basically had two different teaching techniques. One was a brief verbal instruction, and the other was a more in detail teach to goal. So patients had to be able to show they could use the device effectively. And what you can see, so pre-education, these are the proportion of patients misusing an MDI, and this is the discus device. So very high. So without any instruction, patients don't do well. They don't use the devices appropriately or optimally. And then education this was that brief intervention, and this was the more detailed teaching to goal. And clearly that teaching to goal, so more detailed instruction, resulted in significant improvement in the percentage of patients that were using a device appropriately. And this for both the MDI and the discus. Now, the problem is, so this is a significant difference here. The problem is that over time, that the educational benefits seem to wane. Although at 90 days in the MDI group, there was still some benefit, a statistical significant benefit, but clearly the efficacy of teaching waned over time. So when is nebulizer therapy the best choice for COPD medication delivery. And so it's really when patients can't use the other devices. And it's because they are cognitively impaired. They can't generate the sufficient inspiratory force if they have a DPI. They're unable to coordinate the hand breath activity with an MDI, less so with an SMI, but still an issue. Or they can't hold a breath. They can't hold their breath after using the device. And patients, the other group, are patients with inadequate symptom relief with appropriate use of their devices. So, if they can't they're not deriving benefit from using their other device. And then also patient preference. And then maybe there's some patients who have some economic benefit from using a nebulizer. As we discussed, it's generally covered by Medicare Part B, or at least 80%. But what is the evidence comparing a nebulizer with a MDI and DPI for COPD maintenance therapy? So there's not many high quality comparative studies. And with regards to COPD maintenance therapy, studies that do exist generally compared a nebulizer versus an MDI or DPI for delivery of LABA or LAMA. And they've generally shown equivalent efficacy. Although, one study did show that older patients and patients with severe COPD, which they defined as an FEV1 less than 50% of predicted, had a greater improvement in lung function with the nebulizer compared with an MDI or a DPI. And studies comparing nebulizers versus MDI or DPI for delivering LABA ICS or LABA LAMA are not available. And we don't have studies comparing nebulizers versus SMI that I'm aware of. So the evidence base, limited studies, maybe there are some patients that benefit specifically from using a nebulizer versus the other delivery devices. And maybe those are the older patients, very severe COPD specifically. So which of these characteristics are likely to benefit from using a nebulizer? Yeah, so all of the above. All right, so now we have about 15 minutes to answer some questions. Anybody have any specific questions? Have you been, Dr. Ramesh, have you been looking at the chat box? Let's see here. Here's Q&A.
Yes, Dr. Hegel. So I think there's one question that's not answered, but we'll just go over to the answered ones just quickly. So there was a question about what do we prefer for group A patients, LAMA or LABA? And I think, LAMA is preferred over LABA because LAMA has been shown to decrease exacerbations. However, there's no head-to-head studies. They're all systematic reviews and meta-analysis. I'm not sure if you agree with that.
Yeah. No, I think there are a couple small head-to-head studies showing, decreased exacerbations, but the evidence base isn't great comparing LAMA versus LABA. But what the evidence we have is that LAMA is more effective, but clearly LABA is effective. So that's LABA is a reasonable choice. Now, obviously, we don't use a LABA by itself in asthma. So if there's a question whether the patient has asthma, then that would be a contraindication to using a LABA by itself.
And there's one open question about share your thoughts on the use of different types of inhaler devices and the greenhouse impact. How would this influence a decision with what type of device to use, and why have the guidelines not integrated this?
Yeah, I can answer that because I'm old and Dr. Ramesh is not. But the Montreal Accord, which I think was in 1992, phased out CFC. So the CFC containing inhalers, they do have they do have ozone depleting effects, but the HFA, the current and sort of the DPI inhalers don't, nebulizers don't, and the HFA inhalers do not have an effect on ozone or greenhouse gases. So that was in the Montreal Accord in 1992, resulted in the phasing out of CFC containers.
I think, similar to even with asthma, we've, with the new guidelines where we use inhaled corticosteroids in patients with asthma as opposed to as needed short-acting beta agonists, because MDIs have more impact. The propellants in MDIs have more impact on the greenhouse, gases. So I feel like once the symptoms are better controlled, patients don't have exacerbations, they are maintained well on a long-acting regimen, that's another way to decrease the greenhouse effect, I guess.
Yes. Yeah. Okay. Let's see what other questions we have.
And the other one was how to best teach the patients or health authorities to dispose of the inhalers safely.
That's a good question. Yes, that is a good question. And I assume people just throw them in the trash and they end up in our landfills. They cannot be reused. That's a good question. And Dr. Ramesh, any answers to that? I'm not aware of any way to recycle or reuse. Certainly we can reduce, reduce, recycle, reuse. There's no recycle or reuse that I'm aware of.
Yeah, I'm not aware of any that's, better than the other.
Yeah.
Yeah. So, that's a great question, though. We'll try to look into that. Yeah. The next one is, how do you convert the dose of a medication when switching from MDI, DPI to nebulizer version of the same medication?
Yes, that's a good question. So the dosing of nebulizers is an interesting question. We didn't really get into this because generally the studies approval studies have used jet nebulizers and with continuous jet nebulizers, and have not used. There's breath enhanced, where the nebulizer output increases flow increases when you inhale, and then there's breath actuated, and where the nebulizer only delivers medication when you're inhaling. And so those are clearly more efficient at delivering the drug. But now the problem is that these drugs were studied using a jet nebulizer, where roughly 10% of the drug is deposited in the distal lung. And if you use a breath actuated nebulizer, as much as 60% will be deposited. So, and then if you use an ultrasonic or a vibrating mesh, much more will be distributed in the distal airway. So how do you go about dosing when what we have approved was studied in a standard jet nebulizer? And so the answer is we don't know. Those studies haven't been done. Now, generally, our medications have a high therapeutic index. The effective dose is divided by the toxicity is generally high. That's an interesting problem of what to do, and converting over, and basically, we have the inhaled steroids, specifically the nebulized steroid budesonide is available in nebulizer, and available in various DPI and MDI forms. And I think the answer is just to use what's approved, what's FDA approved. I mean, always, if you talk to the companies, the manufacturers, always, this is the dose that was approved, so that's the dose you should use. So it's easy to make the comparison that way. But there's all kinds of issues with regards to using different nebulizer types and the amount of dose delivered. So that is, it's a good question. One that we don't readily have good answers for. But just be aware that if you use like a breath actuated nebulizer with a specific drug, there's going to be a higher drug delivery.
No, that's a great point. So again, balance the adverse effects with the benefit that you're hoping to get.
Yeah.
You have one more in your practice. Do you check peak flows regularly before starting a new DPI? And is there if so, do you use any specific device?
I can take that one. Now we do. We have, we're lucky. We have COPD navigators that do this, and there's the InCheck peak and story flow device. And if people have seen that, it's a handy handheld device that basically it has a different levels of resistance: low, medium, high, and those correspond to the different inhaler types, the different DPI devices. And then I showed you like the minimum and the optimal peak inspiratory flow rate for that given device. So using the InCheck device. So or the specific inhaler or DPI for the InCheck device. And so what we do is, now we don't do this for everybody. If we have a relatively robust appearing person, then we don't check peak inspiratory flow rate in everybody. But if we have an elderly person who there's concern about the ability to generate adequate inspiratory flow rates, because remember, you have to develop the inspiratory flow rate has to be adequate for the given internal resistance to deaggregate the particles to allow distal drug delivery. So we check that, and if they don't meet the minimum peak inspiratory flow rate, we generally won't use that device. That DPI device for that patient. Now, you could argue that, well, the studies don't seem to really suggest that there's a significantly worsening out. Well, the studies are controversial whether or not that worsens, having a mismatch between the optimal peak inspiratory flow, their best peak inspiratory flow in the device, and whether or not you don't achieve that. And whether or not that worsens outcomes is a matter of debate. There's lots of literature on that. But we have decided not to do that, not to use those DPIs for patients who can't achieve an adequate peak inspiratory flow rate, because we have other options.
Yeah, good. We almost do the same thing too, but having the COPD navigator help us with all this. We're
spoiled because we have them. Yeah.
Related to that, there's another question which says, can we extrapolate the peak inspiratory flow rate from FEV1 or peak expiratory flow rate?
That is a very good question. Poor and surprisingly poor correlation. There's a good body of literature on that there is a generally, I can't remember the specific R value, but there's not a good correlation between the FEV1 and the peak flow that you get when you do spirometry and peak XTR, peak inspiratory flow, and whether or not they have adequate peak inspiratory flow rate for a given device. That'd be nice if you did. If you say, hey, FEV1 is this, they're not going to have an adequate peak inspiratory flow rate. But those studies have been done, and there's not an adequate correlation. That's why you have to check peak inspiratory flow rate with the given set resistance using that. The brand name is the InCheck device.
Okay, that's a good point. Then the next one is from one of our participants from Chile. They say that our patient is not guaranteed nebulized treatment. What is the main benefit in public health in terms that have had this therapy? Better life quality or reduced hospitalization? So basically, public health benefit of using nebulizer therapy. I think, from my experience, I would say it's based on the patient. Do they have ventilatory defects? Do they have, some kind of disability where they cannot have this hand device coordination appropriately? So nebulizers are not we don't have to give it to every patient. What do you think about that, Dr. Higwald?
Oh, yes. I think that it has to be highly individualized. I wish there was a simple flow chart that said, this patient needs a nebulizer, but there really is not. There's just so many factors that go into play, and of course, maybe that's a good thing. Maybe we're not going to be replaced by some AI program as physicians. We have to use our judgment. Just actually another thing that one of the attendees gave me a link on the some of
insectile.
our HFA inhalers do have greenhouse impact, which I was not aware of. I have to read more about that. There's a link in the chat about some of the greenhouse gases from the HFA devices, which I wasn't aware of. Anyway, what else do we have?
We have 1 second. Do you feel there is a need to evaluate which nebulizer is the best? And if a drug is evaluated with one type of nebulizer, do you believe there is a need to evaluate the drug in another nebulizer to prove efficacy of the product?
That's another good question. So, multiple different nebulizer brand names, are available. And, this came up recently because when we switched from using a cumulative dose for methacholine, we had to know output of nebulizers, specific output of the nebulizers. And that was problematic because the nebulizer companies really weren't able to provide adequate, most of them couldn't provide, really explicit output characteristics. But I guess the flip side of that is, there's multiple different nebulizers have been used in different studies and have generally shown equal efficacy to MDIs and DPIs when studied. So, I think the thing to do is to get a nebulizer and most of us were forced to, at our institutions, in this specific nebulizer brand, and to use that one, get familiar with it. But I wish we had better information on that, better characteristics of output.
Yeah, related to that, this is a very practical question, I think. When you move patients to a nebulizer after struggling with DPI or MDI, what is their feedback to you?
That's a good question. It's highly variable. There are, I didn't include, there's a couple studies that have looked at patients, what patients desire. So the issue is lots of people are on both nebulizer and an MDI or DPI, right? They'll have a rescue short-acting drug with a nebulizer. And they've asked them, what do you prefer? Do you prefer people that have used both? There's a German study, if I recall, and about half people prefer nebulizers when they've got both, but half prefer nebulizers to the other devices. And there's another study that asked caregivers and or patients, their caregivers, which if they prefer, are they satisfied basically with their nebulizer? Generally 80-90% or plus are satisfied. There's a bunch of different domains, and generally patients are satisfied. There's some literature regarding what patients prefer and how satisfied patients are with their nebulizer. But it's just highly variable. Ramesh talks about that. Okay, well, I think we're at the end of our time, and I know in the chat there's if you have further questions, you can email them to Lily Rodriguez. It's lrodriguez@chestnut.org, and they'll forward them to us. But thank you for Theravance and Viatris for supporting this non-promotional CME webinar.
Thank you. Thank you to our participants as well for spending their time with us.
Yeah, thank you for the folks at CHEST for organizing everything. All right, everybody have a nice rest of your week. Goodbye. Thanks.
Bye.